desperately low on the front line. People with serious mental illness are likely to die, on average, 15 to 25 years earlier than those without serious mental illness, largely from preventable diseases such as heart disease and diabetes. Report after report has confirmed what every mental health worker knows, that the service is in a terrible state, and that the shocking chasm between what is needed and what we are actually resourced to provide is getting larger, leaving an increasing number of vulnerable people and their families in dark and desperate states of mind. The theme tunes seem horribly familiar as the potential for depriving, brutalising and dehumanising mental health patients re-emerges in different settings. To my great sadness, we seem to be moving backwards, the progress made during my early career steadily eroding. Now we have services where desperate patients wait for months to see a psychiatrist or therapist, where the bed shortage is such that we end up sending severely ill adolescents hundreds of miles away from their families, where traumatised refugees are housed in detention centres that are more like prisons than care facilities. Why, at a time when we seem so much more comfortable talking openly about mental health and have so much more knowledge than previous generations, do we put up with sparse, inadequate, and sometimes even abusive services? There seems to be some sort of paradox here, a shadow as dark and gothic as those lunatic asylums of old. Funding is, of course, a huge issue. Health ministers talk recurrently about transforming services and promise more money. But action doesn't seem to follow the rhetoric. Despite all the positive talk, the gap between what we spend on mental health care and the level of need in our society has been growing steadily since the 1950s. The proportion of healthcare money spent on mental health has also declined. Since 2013, the NHS Constitution in England has included a commitment to improve, prevent, diagnose and treat both physical and mental health problems with equal regard. But despite strategies and legislation, we continue to miss this by a long shot. Much of the first edition of this book was written during the COVID-19 pandemic. Like most people, I often felt frightened. The world seemed a dangerous place. As a psychiatrist, I know that a crisis can go both ways and always contains the seeds of opportunity. But early glimpses of values and priorities shifting and the hope of building back better were not sustained after the pandemic. Far from binding us together, our country, the whole world in fact, emerged more unequal and divided than ever, and individuals more fearful, more vulnerable, more unstable. COVID-19 exacerbated an already perilous situation. It is now clear to most people that the NHS itself is on the brink, in desperate need of proper attention, long-term planning and economic investment. Is there a special case for mental health services? Clearly, some of the problems are being felt in other specialties across the NHS, but there are issues of scale and important differences not acknowledged or understood properly that I hope to clarify in this book. Just how much mental health services had lost their way was brought home to me in the first few weeks of the pandemic. The edict from NHS England was to discharge as many inpatients as possible. Clearly the risk of infection was real, but the mental health charity Mind has published research suggesting that in some cases this was done with no review of ongoing